Welcome to VetSciCast, the veterinary podcast validated by vets with the help of AI. Welcome to today's new episode.
Diving deep today into, well, one of the most clinically sensitive areas of small animal practice, surgical antimicrobial use.
It really is. I mean, you're constantly facing that dual mandate, aren't you?
Every single day. You're trying to protect your patient from infection, but you're also supposed to be this great steward against antimicrobial resistance.
Exactly. And that tension is precisely why this material is so critical. We're taking a deep dive today into the European Network for Optimization of Veterinary Antimicrobial Therapy, or ENOVAT 2025 guidelines.
Right.
And this document is really the new gold standard for surgical antimicrobial prophylaxis, or SAP, in dogs and cats.
Yeah, SSI surgical site infections, they're a nightmare for the patient and they're incredibly costly. But the flip side is that prophylaxis accounts for, around 15% of all antibiotic use in small animals?
That's the number. So the entire mission of ENOVAT here is to provide that evidence-based roadmap, helping you balance the immediate benefit of reducing SSI risk against the guaranteed long-term harm of resistance and dysbiosis.
So what gives these guidelines so much weight? I mean, what's the methodology?
What gives them exceptional weight is the methodology. They didn't just meet in a room and agree. They used the GRADE framework grading of recommendations, assessment, development, and evaluation.
Okay.
It's a robust system that pulls in systematic reviews, and it integrates direct input from practicing vets like you to define what's considered a small versus a large, clinically relevant effect.
Ah, so it's grounded in the reality of the clinic floor.
Exactly, not just theoretical data.
Okay, before we get into specific surgeries, we have to lock down the language. This whole framework really hinges on a few key definitions, starting with surgical antimicrobial prophylaxis, SAP itself.
Right, it's simple but critical. Using antimicrobials before an infection has set in, solely to reduce the risk of an SSI.
And then we split the timeline.
We do, and that's where perioperative SAP comes in. It's that critical window. It starts with administration, say 2 hours prior to surgery, includes potential redosing during the operation, and the last dose must be given not more than 24 hours postoperatively.
That 24-hour mark is the hard line then.
It's the hard line. If your procedure ends at 4 p.m., you might give a final dose that night or first thing the next morning, but that is it.
And anything beyond that?
Anything beyond that final dose within 24 hours officially slides us into the next category, postoperative SAP.
Which is defined as?
Just continuing those antimicrobials beyond the 24-hour mark purely for infection prevention. And you'll see the evidence strongly separates these two. The ENOVAT panel leans very heavily toward eliminating postoperative use altogether.
Got it. Now, let's talk recommendation strength, because this is where the rubber really meets the road for clinical decisions. We have strong and we have conditional.
A strong recommendation means the panel is confident. They believe nearly all animals in that specific situation will benefit from the action or inaction that they suggest. This should be guiding your policy, your SOPs.
Okay, but I saw they sometimes issued strong recommendations against SAP, even when the data certainty for a lack of effect was low. That sounds a little counterintuitive. Why would they do that?
That's a fantastic question. It's because they balanced it. They said, okay, the desirable effect, which is reducing SSI, might be trivial or non-existent, and our certainty of that benefit is low. But
Right, how is certain?
the anticipated harm of contributing to AMR and causing dysbiosis is high certainty. So if the undesirable effects clearly outweigh the trivial benefits, the recommendation is strong. Follow the policy.
That really shifts the responsibility, doesn't it? It's on you, the clinician, to justify why you would deviate from that.
It does.
Okay, so if strong is clear policy, what about the conditional recommendation? This seems to be the one that requires the most critical thinking.
Absolutely. A conditional recommendation is your signal that the evidence is inadequate or uncertain. It also means the values and preferences of the client, or you, the DVM, might vary a lot.
So it's not a policy.
It's not a policy. It means you must apply your clinical judgment, weigh the specific patient's risk profile, and have a detailed, evidence-based discussion with the client about the risks and benefits. It's personalized medicine.
Okay, with that crucial distinction made, let's start with the most common surgeries we all see every day, clean soft tissue procedures.
Yes, and this is where the guidance is strongest and clearest, and perhaps most challenging to traditional practice. Let's start with neutering.
For neutering, there's a strong recommendation against using perioperative SAP. The evidence just showed the absolute risk reduction was so marginal it was barely measurable.
And this really highlights the gap between evidence and habit, doesn't it? Despite this very strong recommendation from ENOVAT, surveys in the UK and Australia show that 30 to 40% of neutering procedures still routinely include perioperative antimicrobials.
It's the fear factor, right? That one time you skipped it and the patient got an infection that haunts you.
It does. But that fear factor is expensive, both for the client and for public health. And that strong stance is reinforced in the postoperative period. Strong recommendation against postoperative SAP for neutering.
And the rationale?
It's definitive. The undesirable effects of AMR, dysbiosis, and even owner exposure, they just overwhelmingly outweigh any trivial desirable effects. The procedure has a naturally low SSI rate.
So what about other common clean soft tissue procedures? Let's say a routine splenectomy, dermal mass removal, or an XLAP. Does that guidance hold?
Yes, it does.
Yeah.
Recommendations 3 and 4 maintain that same strong stance. Strong recommendation against both perioperative and postoperative SAP for those as well.
Okay, so if it's clean, the message is clear. Avoid antibiotics.
That's the message.
All right, here's where we move into the nuance. Let's talk about clean contaminated soft tissue procedures, where a microbial burden is introduced. The recommendations here get more complex. Let's start with urological procedures.
So, recommendation 5 is a conditional recommendation against the use of perioperative SAP in urological procedures. So the panel said, generally, avoid it.
I'm guessing the conditional part of that is huge here?
It's the defining feature. This recommendation is completely contingent on your confidence as the surgeon that the urinary tract is not infected.
So if I'm certain I'm operating on sterile urine and a healthy bladder wall.
Then the risk of SSI is very low, making the antibiotic risk unwarranted.
But what if I have any doubt? If I see signs of cystitis or I didn't get a pre-op culture?
If there is any doubt, you should immediately reclassify it, treat it as a contaminated procedure, and follow that advice.
Got it. And for postoperative management in those urological cases, R6.
Still a strong recommendation against postoperative SAP. We're always pulling back on duration wherever possible.
Okay, let's shift to gastrointestinal procedures. Contamination potential is high. Here, the conditional recommendation flips, right? R7 is a conditional recommendation for perioperative SAP.
It is. This is a high-stakes area due to the significant microbial load in the bowel. However, and this is a critical exception, within R7, they recommend against perioperative SAP for surgery involving the stomach alone, so a gastrotomy.
Why the exception for just the stomach?
It's because the stomach generally has a lower microbial burden, especially in animals with normal gastric pH. The acid helps mitigate risk, and it's often more controllable surgically.
But as soon as you go into the small intestine.
The stakes immediately increase, hence the conditional 4.
And what about postoperative SAP for these GI cases, even with that higher inherent risk?
Still a strong recommendation against. The panel found that even in clean contaminated GI procedures, the evidence for a postoperative benefit is just lacking, and that high certainty of harm from duration remains the driving factor.
Finally, in this category, what about things like BOAS interventions? Those are technically clean contaminated since we're entering the oropharynx.
Recommendations 9 and 10 are both strong recommendations against both perioperative and postoperative SAP. The message is to resist that gravitational pull towards antibiotics unless the evidence truly mandates it.
Okay, let's move into the category where intervention is almost always necessary. Contaminated soft tissue procedures. So this means a confirmed infection or major intraoperative contamination like a big GI spillage.
This is where we see that definite shift in favor of intervention. Recommendation 11 is a conditional recommendation for perioperative SAP. The rationale is direct. The infection risk is so high that the potential desirable effects do outweigh the undesirable effects.
And for postoperative management here, R12, this is one of the few places where continuation is conditionally recommended.
It is. R12 is a conditional recommendation for postoperative SAP, specifically suggesting 3 to 5 days. This is where your clinical judgment and diagnostics become paramount.
So you're not just putting them on it and forgetting.
Absolutely not. You must review the patient daily and, importantly, adapt or de-escalate the therapy based on culture and susceptibility results as they come in.
And why 3 to 5 days? Seems fairly specific.
It's extrapolated from human trauma guidelines. It reflects that necessary extension when a procedure gets reclassified as contaminated. But it's not open-ended. The goal is always the shortest effective duration possible.
Okay, moving into orthopedics. The risk profile here changes significantly based on whether or not we're implanting foreign material. Let's start with non-implant orthopedic procedures like arthroscopy or a hemilemonectomy.
For perioperative SAP, that's recommendation 13, and it's a conditional recommendation against. SSI rates for procedures like hemolaminectomy without SAP are remarkably low, around 0.6%.
Wait, but for hemolaminectomy, even if the SSI risk is only 0.6%, the consequence of that infection is catastrophic. So why did the panel feel a conditional against was still justified, knowing that risk?
That's the core of the clinical discussion. The panel acknowledged the high consequence, but the baseline risk is so incredibly low, and the certainty of systemic harm from unnecessary antibiotics is high.
So it's that balance again.
It's that balance again. Therefore, avoiding the antibiotic is conditionally preferred. And for R14, postoperative SAP for non-implant orthopedics, it remains a strong recommendation against.
Now, implant procedures, excluding TPLO for a moment, so things like fracture fixation. Recommendation 15 covers perioperative SAP.
And this is a conditional recommendation for SAP. The conditionality here is justified by two big factors: the perceived greater risk of SSI when you're placing foreign material, and the highly challenging, costly nature of treating implant-associated infections.
Right, if you get an infection around an implant, you're in for a world of hurt.
A world of hurt. The cost, the pain, potential for long-term antimicrobials, or even surgical revision, it's significant. The high consequence tips the balance in favor of prophylaxis.
But we give that perioperative SAP, and then we stop the clock at 24 hours. R16 is a strong recommendation against postoperative SAP in these cases. And I notice this one is informed by moderate certainty evidence, which is higher than most.
Yes, and that's significant. It shows real conviction based on better data that extending antibiotics beyond 24 hours in elective implant surgery is simply not beneficial and contributes to harm.
Let's wrap up the specific procedures with the big one: tibial plateau leveling osteotomy, TPLO, in dogs.
For perioperative SAP during a TPLO, that's R17, we have a conditional recommendation for use. It's similar to other implants: high risk, high consequence of failure.
But then R18, which covers postoperative use in TPLO, is a conditional recommendation against. We should probably emphasize the strict interpretation of that 24-hour window here.
This is vital, especially for TPLO. Some past studies that suggested a benefit for longer duration may have mistakenly grouped dogs receiving antimicrobials for, say, 20 hours into the postoperative group. It blurred the definition.
So it wasn't a true post-op group.
Exactly. ENOVAT is crystal clear. SAP should be discontinued at the end of the procedure or within that strict 24-hour perioperative window. If you're thinking of going beyond 24 hours for prophylaxis, the panel conditionally suggests against it.
Okay, let's pivot to the practical, consensus-based advice the panel generated in their ungraded guidance. Let's start with drug selection.
Right, so the panel working across Europe didn't name specific brands, but they gave very clear advice on targets. For standard prophylaxis, you need reliable activity against staphylococcal species.
And if you're going into the GI or urinary tract?
Then your coverage must expand to include gram-negative activity, specifically covering Enterobacteriaceae. Metronidazole is only indicated as an add-on if you're entering the colon.
What about specific agents?
Cefazolin is widely favored, but you really should look at your local resistance patterns. Parenteral amoxicillin clavulanic acid or ampicillin might be alternatives if beta-lactamase-producing staph are uncommon in your area.
Timing is everything for SAP. Where does the needle land on administration?
It has to be IV. Intravenously 30 to 60 minutes prior to the first incision. This ensures you have therapeutic levels at the surgical site precisely when contamination risk is highest.
So no IM, SQ, or oral routes?
Not for that initial dose.
And what about redosing for those long procedures? We're talking about time-dependent drugs like beta-lactams here.
Yes, we redose because they are time-dependent. If the concentration at the site drops below that therapeutic level, your prophylaxis clock basically starts, so you have to stick to the half-life schedule. Redosing is indicated if the procedure time exceeds 2 elimination half-lives of the drug.
Can you give us the critical interval specifics?
Yeah, based on pharmacokinetic analysis, cefazolin is suggested roughly every 2 hours at 22 to 25 milligrams per kilogram. For amoxicillin clavulanate, or ampicillin, the half-lives are shorter, so that interval shrinks to about every 1.5 hours at 20 milligrams per kilogram.
Finally, the guidelines address a scenario we've all faced: the procedure that unexpectedly runs long.
Right, so perioperative antimicrobials are recommended for any procedure scheduled to last longer than 90 minutes. But if unforeseen complications drag a simple XLAP past 90 minutes, the panel suggests you should consider administering an antimicrobial and then managing the case according to the contaminated procedure recommendations.
Because the SSI risk is just spiked.
It spikes significantly due to the length and complexity.
So after reviewing all 20 recommendations, the main takeaway for you, the practicing DVM, really seems to be a definitive shift. The default position is now against antimicrobial use.
Absolutely. The vast majority of procedures and almost all postoperative regimens now carry a strong recommendation against SAP. The responsibility is now firmly on the clinician to justify why an antibiotic is necessary, rather than just defaulting to its use.
We know there are barriers to implementation, though. There's client pressure, can I have some antibiotics to take home, and just deeply ingrained habit.
Of course. But the data from places like the UK's Canine Cruciate Registry is encouraging. It shows nearly 2/3 of vets doing cruciate repair already skip postoperative SAP. So change is happening. It is possible.
And that consensus is built on solid ground. Even when the evidence for benefit is low certainty, the certainty of harm from AMR is high. That's what's guiding this.
That's the key.
As you move forward, just remember that this is an evolving, evidence-driven field. The ENOVAT panel suggests that the next refinement of these guidelines is already scheduled for 2030. That means continuous critical review of our daily practice isn't just a suggestion, it's a necessity. We have to maintain the highest standard of care while protecting our shared global health resources.
And the research that needs to happen now is really defining the precise impact of true postoperative antimicrobials and, frankly, improving practitioner adherence to these very recommendations.
Welcome to Vet SciCast, the veterinary podcast validated by vets with the help of AI. Welcome to today's new episode.